changer. So as you can see on the screen, we'll be discussing antenatally diagnosed renal anomalies and some of the postnatal management. It's a wide topic which is rapidly advancing over the years, and we will cover some of that ground today. Okay. So we have 6 panelists, of which one of them is offline, that is online, and will be joining us from Rajasthan, and one of them is a pediatric surgeon. So our first panelist is Dr. Surendra Bisht. He is the current national treasurer for National Neonatology Forum, and is a master trainer for quality improvement. He has been executive board member in the previous EB in 2019 and 2020, and is an active NRP trainer and trainer of various programs. Then we have. How does this move? Huh? Okay. Then we have Dr. Sunil Gotwal, who is joining us online from Rajasthan. He is an assistant professor of pediatrics and has quite a few publications. Then we have Dr. Sarath Chandra, who is with us physically. He is director and chief of child health, and also the winner of various awards at an international forum. Then we have Dr. Ravi Sachan. Can we have silence, please? Then we have Dr. Ravi Sachan, who is an associate professor at UCMS Medical College, Delhi, and is the secretary of National Neonatology Forum, Delhi. We have Dr. B.S. Prasad from Karnataka itself, from Davangere. He is the dean and principal and professor of pediatrics at SSI Medical College, and has done his training in the UK. And we don't have yet with us, but he'll be joining us soon, Dr. Nijagal Mutt, who is a pediatric surgeon from Tumkur. If the organizers can ensure that Dr. Mutt comes, Mehika, can you call Dr. Mutt? He's not there. Okay, yeah, thank you. So with that introduction, and I'm Dr. Somshekhar Nimbalkar, who's moderating the panel discussion, and I'm a professor of neonatology at Pramukh Swami Medical College. So we'll start off with the first question as to what are the various urologic abnormalities. Sorry. Okay, so what are the various urologic abnormalities that can be detected antenatally, and can they be listed by Dr. Surendra Bisht?
So in this study which was published there, the review from pediatric clinics, and they showed that almost we have in this all anomalies were around 609, and hydronephrosis is the commonest one of them, followed by multicystic dysplastic kidney, unilateral renal agenesis, duplicated kidney, PUV, solitary renal cysts are lesser in number, and you have other things, bladder extrophy. These are a few of the anomalies which can be detected antenally by ultrasound. And
next one.
Okay. So how did they fare of all these anomalies? If you see, knowing about antenatally about renal anomalies is important, because it can lead to induction of abortion or intrauterine death in certain number of almost 26.8 in cases antenatally. It led to some decision by the obstetrician that this pregnancy need to be terminated and it needs to be aborted. It's in almost 20%, in 1 in 5, it led to fetal neonatal death also. And if you see, there are quite a number of children, almost 1/3 to 1/4 to 1/3, which were alive with normal renal functions, and there were almost 10% or 7 to 10% which had some renal disease which required care by a pediatrician or neonatologist later on. And to understand what anomalies can occur, as a perinatologist or as an obstetrician, people need to understand the development of the the kidney from where they're from mesonephros, metanephros, and how the birds come and what all anomalies can occur. So I think this was just to show those things at different ages it can be done. Thank you. I think other slide is also.
This is not moving forward. Can it be moved forward? Okay.
So how it is the kidney is placed in the pelvic region, then it gets ascends up from pelvis to up. All those things need to be understood by the parent doctor.
Yeah, thank you, Dr. Bish. So as you can see, quite a few anomalies are there, and 25% of them actually end up with a good renal function and 25% with an abortion. And understanding the entire development is actually important. So we'll go to the next question. And Dr. Sunil Gothwal is online, and he's joining from Jaipur. So is Dr. Gothwal online, and can he answer this question, please? The question is, can you discuss renal dysplasia detected antenatal inclusive of ultrasound findings? Do we have Dr. Gothwal? So I don't think, is he online? So since he's not online, but he has sent his answers previously, I'll just go through what he has sent previously, and I'll discuss it. As it says, there are a lot of dysplastic kidneys that are abnormally developed, and they're variable in size, and they can occur 1 in 5,000 fetuses unilaterally and almost 1 in 10,000 fetuses in bilaterally. They can be a part of various associations like Bardet-Biedl, Wetter, renal coloboma, etc. And a lot of ultrasound findings can detect many of these, and they typically show large bright kidneys with or without cysts, and at the routine 20-week anomaly scan. So it's we may be saying it's routine, but it definitely should understand that a lot of this is not available to a large population in India. Dysplastic kidneys are actually smaller and larger and echogenic, and the degree of abnormality can vary in terms of abnormal size, brightness of kidney, visibility of cysts, number of cysts, volume of Leica, and other non-renal anomalies. So a lot of findings can be detected on the antenatal ultrasound, and as you can see that it shows the area of dysplasia. I can't use the pointer currently, but you can see on the screen that cystic dysplasia at 21 weeks of gestation, and in the other in diagram B, you can see it in the coronal planes. So a lot of these can be detected antenatally, and we have to understand that many of these are multiple hypoechoic non-communicating cysts with minimal normal renal parenchyma. So most of it is actually cysts with, and many of these dysplastic kidneys will be small kidneys, and the bladder may not be visible when these kidneys are dysplastic because urine is not being formed antenatally. So many of these actually might end up with abortions. Okay, so you can see that the cysts do not communicate with each other. I don't know how good visibility is, but you can see a lot of cysts in both the slides. These do not actually communicate with each other. Okay, so the prenatal management for these patients is you should look at other organs and see if there are do a chromosomal analysis and see if a lot of other renal anomalies are there or any chromosomal anomalies are there. Using an MRI and an ultrasound together increases the sensitivity of detection from 85% to 95%, and whether to continue pregnancy, etc., can be decided on discussion with the parents. And if they want to continue, then it is important to do serial ultrasounds every month, 1.5 months or so. It is obvious that if some of these babies survive till to birth, many of them may not have a very good renal function postnatally, and they will have other stuff like hypertension, etc., later on. So coming to the next question, can he join later on? Can he be joining? Yeah. So Dr. Sarath Chandra is here, and he will discuss in brief polycystic kidney disease, inclusive of ultrasound findings and other prognosis. Yeah. Closer.
In PKD, the early kidney development looks always normal, but subsequently the cysts develop, which will destroy the normal surrounding tissue and lead to a progressive kidney enlargement, and with renal and extrarenal complications. There are two major types. One is recessive and another one is dominant. So in recessive type, the severity of the renal pathology appears directly related to the proportion of the nephrons. And they're affected by cysts and correlate with the type of PHKD1 mutation. And they have the worst prognosis. In autosomal dominant, the commonest inherited renal disease, and it is more common than recessive one, and it occurs in 1 in 1,000, whereas the recessive one occurs in 1 in 20,000, and it accounts to 7 to 10% of all adult dialysis population. So the PKD1 accounts to 85 to 90%, and PKD2 is around 10 to 15%. And both can present antenatally, although the recessive tend to be more severe, potentially resulting in life-threatening perinatal complications. And neither usually present directly with cysts, and instead they more appear to be like right kidneys antenatally. So if you look at the ultrasound findings, in recessive type, you can see that there's a uniform massive enlargement of the kidneys with diffuse echogenicity, and both cortex and medulla show that that's right, and there's loss of differentiation, and it is associated with oligohydramnios, and hyperechogenicity of the kidneys have been demonstrated as early as 12 to 16 weeks, but most of them usually by 22 weeks that you'll be able to detect. And evidence of renal enlargement is usually by 24 weeks. And diagnosis may not be apparent until third trimester antenatally. It is always associated with hepatic fibrosis, even it can be detected antenatally. For dominant type, and they're reported usually as normal because you do not see changes initially, and the cysts cannot be seen usually up to 30 weeks of gestation. And there will be variability between the kidneys and a mixture of small and large cysts at different stages of cystogenesis. And amniotic fluid usually is normal, and this is one of the most important form to differentiate between the recessive type and the dominant type.
Thank you. So as we see, autosomal dominant is actually more prevalent and less detectable. Many times they're not detected, as is mentioned, even in the adult
There is an
population.
increasing
Some of the patients who
recognition
undergo
that
dialysis for a
parents
long
play
period
a
of time
very
actually have
critical
this kind
role
of
in
cystic
promoting the
disease,
health outcomes
which may
of
have
the
been
low birth
undetected
weight
because
babies and
we
preterm
probably
babies
didn't have a lot of
admitted in an ICU.
ultrasonography back
Despite a
then
large
when they were
body
growing
of
up as children.
literature to support the family
Most of the
engagement
management
in
is
baby
actually
care, we do
milder
not
forms they
find the
just follow,
parents being
and
involved.
then for severe forms like
So
PKD
this
dysplasia, we'll
presentation,
see
through this
further
presentation
in the
today, I
next
would
slides what
like
going to
to
happen. You want to add
talk to
anything?
those
Only
in
multidisciplinary
ICU's
approach seems to start
facilities
right
which
from
are not
antenatal counseling.
yet, which have not yet
So
started
the
with the
next question to Dr.
family-centered
Ravi
care.
Sachan is what is called as LUTO, so lower urinary tract obstruction. So what are the various features that can be detected? And this is one of the most commonest things that
Very
we
good
will be
morning to
seeing
all. At the outset,
on
I would
ultrasound.
like to
And
thank
can you discuss the antenatal
I would
ultrasonography
like to
findings?
thank the organizers for giving me this opportunity to deliberate on
Can't hear.
family-centered care in an ICU. There is an increasing recognition that parents,
Hello.
they play a very
As far
critical
as
role
antenatal ultrasound
in promoting
sonography
the
is
health
concerned,
outcomes of the low birth weight babies
ultrasonography
and the
is
preterm babies.
means quite
Despite a large
specific,
body
and
of
sensitivity is
literature to
very
support the
high.
family engagement.
And specificity
So
is
this talk
little low,
is
and it is close to the
mainly to motivate those who have
93%
not
and
yet started
43%
and
respectively.
to
So if you
encourage
find it, there are some features suggestive of antenatally which are has got a hydronephrosis, which may be unilateral
and to
or bilateral.
motivate them to continue.
Ureteral
Those who have
dialysis or
already
renal
started,
dialysis,
we
they are
would like to
dilated.
motivate them
And there is enlargement
to
of the
continue
bladder,
with
which we
the
call megacystis, and
family-centered
there is
care.
a bladder thickening, which is
So this is
to be
the
more than 2
proposed
mm.
outline. I will
And
be
the
talking
posterior
about
urethral wall is
family-centered.
dilated, and that is what is classically called as a keyhole sign. And there's absolutely oligohydramnios in the second and third trimester, which is also independent risk factor for the fetal survival. And as you can see in the ultrasonography picture A, there is a thickened wall, and the bladder wall is thickened, and the
मैडम आवाज नहीं आ रही है। हम्म।
Not allowing me to change the slide. Can you change the slide, please? Yeah.
Yeah, vesicosynthesis is the most simple thing. It just needs a percutaneous insertion of a needle into the bladder and take out the urine. But the drawback of this is it must be repeated several times a week, and it is primarily a diagnostic tool rather than a therapeutic one. Next one.
Slide change, please. Okay.
Vesicoamniotic shunting, this is the most common method to relieve the pressures of bladder or the relieve the urinary tract obstruction. And in this, it is done around 24 weeks. When you have a diagnosis of LUTO during 21 to 22 weeks, and it is stage 2. There are varieties of criteria which needs to be taken care of. And a pigtail catheter is inserted into the bladder. The proximal will be in the bladder and the distal will be in the amniotic cavity. And it is just like a diversion. It is nothing but an SPC, where the urine is drained from the bladder onto the outside cavity. Outside cavity is the amnion. That is how it is done. And efficacy is still not clear about this. And efficacy, they are telling in the recent papers, they're telling around 50% is the success rate. Even with the best of the efforts, it is around 50% is the outcome. And the last one is fetal cystoscopy. It is used for the diagnosis as well as the treatment of lower urinary tract obstruction. And it is not performed very in most of in all the centers. It is done only in few centers in India, and abroad it is gaining more importance because you can diagnose, you can treat, and the prognosis is far better when you do it, when you give a complete treatment. And it is performed under maternal epidural, and a fetal anesthesia is given, and using a 1 or 1.3 mm cystoscope, which is not at all available, which is very rarely available in India. And there are varieties of ablative procedures which are used, like hydroablation and guide wire perforation or a laser fulguration. All these things are varieties of methods to make a hole in the valve which is present in the posterior valve. And fetal cystoscopy is more effective than vesicoamniotic shunting, but still the studies have not shown how much is the outcome and all, because we don't have large trials
Numbers
on these things.
Yeah, because these are rare anomalies. People who do the trials don't have large populations unlike us, and large populations like us don't do it and don't have trials. So it's going to be difficult.
Most importantly, the thing is, see, we can't get all the patients with stage 2 only.
Hmm.
If it is stage 1, we don't need to do anything. If it's stage 3 or 4, obviously it's as a poor prognosis as earlier told.
Yeah, thank you. So we have the next question for Dr. Bish, but we'll not go there. We'll go straight to Dr. Mutt's next questions. And so we'll proceed to the postnatal, and we'll come back to these questions later. Okay, so because I thought we might miss those questions later on, and I don't want that to happen. So because we want to stop at 9:50, even though we started late. Yeah, so question to Dr. Mutt. So what are the various surgical approaches for antenatal hydronephrosis in the postnatal period? And what are the various things that you can do? Yeah.
A surgeon is required.
Because the next slides have videos, so there's no point in moving the slide unless there's no point in seeing it without the slide. So we are stuck here. So anyway, so so you want to discuss without the slides?
What we
Yeah.
do.
Okay, so okay, we have moved the slide. So let me check. Wait. It has gone too farther. Here. Okay, great. Please go ahead.
Vesico-ureteric reflux, when you have an antenatal diagnosis of hydroureteronephrosis, then we need to evaluate with an MCU. The right hand side, the picture is showing a VUR. On the left hand side, left VUR, grade 3 to 4 or 5, you can tell. The VUR can be unilateral, bilateral, and a DMSA needs to be done if there is a VUR. And in a male child, usually most of the times what we do is when we are planning for an MCU, we usually plan for circumcision on that day only because we do it under anesthesia. Because the child should not be hurt, so we plan for an MCU with circumcision together. And a continuous antibiotic prophylaxis is required in a case of VUR. And in a female child, usually continuous antibiotic prophylaxis is good enough. And if the reflux is very bad, means grade 3, 4, or 5 with recurrent UTIs and a reduced function, later on only intervention is required only after 1 year. Most of the times we don't do interventions till 3 years of age. But sometimes on continuous antibiotic prophylaxis, if the child has recurrent infections, then we need to consider a ureteric reimplantation.
Okay.
If it is a low grade VUR with recurrent UTIs, then we can have a deflux, which is a cystoscopic procedure. It's a minimally invasive procedure.
Thank you. So next one is
PUV, post-urethral, there are varieties of things which needs to be done. There are various things which can be done in a case of PUV. We usually do if the child is clinically stable. Clinically stable means if the creat is around 0.5, 0.6 or normal creatinine or a little bit on the higher side and without any UTI or without any scarring on DMSA, all these things we need to consider. Then we go ahead with a fulguration. If the child has recurrent UTI and if the child is septic, then we need to do a diversion procedure. Most of the times we do a vesicostomy or else you can do a ureterostomies also.
thank you. So this is a video.
And this
Can
is the
Rahul-
video
Dr.
showing-
Rahul, can you play the video?
PUV fulguration.
Can you play the video? Click कर दो ना, नहीं हो रहा है. हाँ, there is a video there. It's not getting clicked. It's a very nice video actually. I don't know why it's not playing. This is a video, right? Click on the video, right? Not playing. At least go to the next slide then. Go to the next slide. Next slide, please. हाँ, मुझे भी जाना है यार. Yeah, okay. Okay.
This is a case of ureterocele. Ureterocele is nothing but the dilatation of the lower ureter, where you need just a puncture. The complications of this procedure, even the cystoscopy and puncture is done, the complication of this procedure is it can have a reflux later on. So we need to be wary of that and we need to evaluate that. And you can see that the incision is made on the lower.
Yeah, sorry.
Can you please-
Yeah.
You can see the incision made on the lower ureter. So this is how it is done.
So we'll go back to Dr. Bisht and we'll start questions for Dr. Bisht as to whether he can discuss the antenatal grading of antenatal hydronephrosis. So I think this is Dr. Bisht's question.
So, thanks. So there are many causes of antenatally diagnosed hydronephrosis. Almost the most commonest being in 41 to 88% is transient dilatation of the collecting system. Upper and lower urinary tract accounts to 10 to 30%, including the uretropelvic junction obstruction. Ureterocele and ectopic, as Dr. Nishikal said, is around 5 to 7%. UV junction obstruction was around 5%. PUV is a little rarer, 1 to 2% only. And non-obstructive processes such as reflux can be seen in 10 to 20%. Multicystic dysplastic kidney, not a good condition, is around 4 to 6%. And other rare conditions can be congenital ureteric stricture, cystic kidney disease, and other can be seen. Next. Several systems have been developed to diagnose and grade the severity of fetal hydronephrosis. Were very simple, and the earliest one was renal pelvic diameter, followed by or simultaneously with Society of Fetal Urology criteria, which we were using in our fellowship days. Now, the latest is urinary tract dilatation, classification system. So this was the one, this was the most easy. You just have to do a ultrasound measurement of the maximum AP diameter of the fetal renal pelvis, known as the RPD. And this is usually in the second and third trimester. And RPD is a measure of collecting system dilatation, but it does not reflect the extent of hydronephrosis and the parenchymal changes, such as the increased echogenicity, thinning, or caliectasis. And there are factors which may affect the renal pelvic diameter, which can be just gestational age, maternal hydronephrosis, maternal hydration at that point of condition when the ultrasound is being done, and the degree of bladder distension. According to this, just as a backup. Very simple. It was that in the second trimester, if any RPD is more than 4 millimeters, so 4 to 10 was this. Anything going beyond 10 was actually severe hydronephrosis in the second trimester. And while in third trimester, when you do a repeat scan or you find it in the third trimester, the values are 7 millimeter to diagnose mild, and more than 9 to diagnose moderate, and more than 15 to have severe. Society of Fetal Urology actually used the degree in site of pelvic dilatation and the number of calyces seen and the presence of and severity of parenchymal atrophy. And so there were 4 grades according to this, where the renal pelvis is only visualized, followed by renal pelvis, as well as few, but not all calyces are visualized. In grade 3, they are all visualized, and grade 4, according to this, there is some changes parenchymal. They are parenchymal thinning also. This is the latest classification, and this is actually made by a panel of radiologists, nephrologists, and urologists together. And this is stratified based on gestation age, whether the direction is antenatal or postnatal, and they have the following 6 ultrasound findings, which is the anterior and posterior renal pelvic diameter, calyceal dilatation, renal pelvic parenchymal thickness, renal parenchymal appearance, if there are bladder abnormalities, and if there are urethral abnormalities. If you see, and they are, it is both antenatal and postnatal. So there is one on antenatal presentation. There are 3 grades from 1 to 3, and there is postnatal P grade, P1, P2, P3, depending on all these 6 parameters.
Thank you. Is Dr. Gothwal online with us?
Yes, sir. Yes, sir, I am here.
Dr. Sunil Gothwal online with us?
Yes, sir, I am here, sir. Yes, sir, I am here, sir.
Is Dr. Gothwal online with us?
Yes, sir, I am here, sir.
Okay, we can hear you barely, but can you answer this question? I'll move the slides. Can you discuss the postnatal evaluation of antenatal hydronephrosis? Can you give more volume to his voice?
Volume.
Yeah, I don't know whether you can see the screen.
Volume.
Yeah, okay, good.
Volume बढ़ाओ, screen दिखाओ एक बार मुझे. Show the screen. Screen share करो. Screen. Slide. Okay करो. Okay. Slide. Show me the slides. हाँ चलो यहाँ से कर दो, कोई बात, शेयर कर दो नीचे, around 50 करो.
Dr. Gothwal, can you just see the slides and then talk from there rather than sharing the slides? We don't need you to share the slides. We need you to speak.
But I am not able to see the slide from your side, sir. From your screen, I am not able to see the slide, sir.
Please share our screen. Please share our screen.
Yes, please share. Please share the screen.
Please share our screen, your screen.
Yes, sir. Share.
Dr. Gothwal, can you see our slides?
Yes, sir. Now.
Can you please go ahead?
Sir, the aim of the the aim is that any neonate with antenatal hydronephrosis should be assessed for their overall health, for the renal condition, for lower urinary tract function, the presence of complications, including urinary tract infection (UTIs), in addition to determine the etiology of the antenatal hydronephrosis. And the other aim is the diagnostic strategies should be with minimal cost, non-invasiveness, and leisure morbidity.
Yeah.
Sir. So next slide, please.
Indications, okay, yeah.
I'm not able to see, sir. Here is the only M is there.
Your screen sharing is paused. Kindly, please do your technical stuff instead of talking. You have wasted at least 10 minutes of the moderation today.
Sorry, sir. इसको पीछे करो.
Not
Enter.
acceptable. Can you see our slides?
Yes, sir. Yes, sir. I am able to see the slide. Sir, the diagnostic workup is the detailed history and physical examination, urine analysis for all cases, serum creatinine in case of bilateral hydronephrosis, electrolytes in cases of impaired renal function, urea and creatinine in the newborn after 48 hours of the birth, UAC in all infants with history of antenatal hydronephrosis, nuclear skin and voiding cystourethrogram in all cases with altered UAC finding. Degree of antenatal hydronephrosis and oligohydronesis are poor prognostic factors, and we have to evaluate in postnatal UAC all the different grading system that is already told by Dr. Beast in previous presentation.
Can you show the next slide, please? Next slide. Yeah.
The timing of the first postnatal.
Dr. Gothwal, you can skip this slide because Dr. Sarath Chandra will probably discuss it in detail.
Okay.
Yeah. Thank you very much. We'll go to our slides and we'll have Dr. Sarath Chandra answer his question. Various postnatal management strategies that are followed depending upon the severity and the various severities, please.
We have wide spectrum conditions right from pathological to transient dilatations. The transient are the most commonest. They account to around 41 to 88%. And the more pathological, they're always lower and rare. The megahertz, that's the rarest one at 5%. And then you have Brown-Belly cystic kidney disease and other congenital problems. Next slide, please. So postnatal management of children. Postnatally, we need to get an ultrasound. Always ask your radiologist to grade it according to either SFU or UTD. And initially, we need to divide them into non-urgent or urgent. And if it is a non-urgent problem, then by end of the third week, definitely you need to get one ultrasound. And intermediate ones, it is at least within the first week, and urgent ones, that is at around 1 to 3 days. Next slide. So based on that, once we get the SFU classification, the grade 1 and 2, probably they need only follow-up. And for grade 3 and grade 4, they require antibiotics till the final diagnosis has been arrived. But it is at the discretion of the treating pediatrician as well as the urologist. So you do for grade 3, we go to VCUG and renal isotope, and it should be followed every 3 months by ultrasound with cap and circumcision if required. And grade 4, cap till all investigations are completed, and then go to VCUG. If there is VUR or no VUR, again, we grade it accordingly. If there is VUR, we go for renal isotope and to find for renal scars. Then if there is no VUR, we go for renal isotope for obstruction. And if there is no obstruction, then follow up again. And surgery for PUJ if there is an obstruction. Otherwise, just keep following up till the diagnosis is arrived.
Thank you. Dr. Ravi Sachan, the question next to you. What is your follow-up for patients? When do we expect and how do we go about the follow-up?
Okay, if antenatally diagnosed due to, and then we need, as per the management discussed postnatally, and then we need a certain follow-up. And for the follow protocol, management is entirely based on the observation and with the repeated ultrasonographic scan, and to look at whether the disease are resolving or stable or deteriorating in terms of hydronephrosis and developing hydroureter, and the signs of worsening and obstructive features are more prominent. And it requires a long-term follow-up especially for the ANH, and though the frequency and the time at what length it is to be followed, it is still not very consensus. But late symptoms of worsening should be considered for a long-term follow-up, and that requires up to 5 to 6 years of. And there are various studies has shown that that the baby may require may develop symptoms, especially for the pyeloplasty may require a little early, and then depending upon the Society for Fetal Urology grades are concerned. Suppose this is a severe variety of SFU, then it requires symptom may develop little early. But overall, the main next slide, can sir. The main management of is only it is the consensus. It has been agreed that with the moderate and severe hydronephrosis like SFU grades 3 and 4, they require a frequent follow-up. And as the other panelists has already told, the features with mild to moderate disease, they need to be less frequent and then the follow-up. And if they are detected at early at 1 month, suppose, and then basically entirely a conservative management, and it is mainly based on the observation. And if it later is the follow-up is complicated by the UTI or something, pains are associated, and definitely the VCUG, voiding cystohystogram, and the renal scan should be considered depending upon the severity of the disease.
Thank you. So we have Dr. Prasad now with the next question. Because a lot of imaging techniques are done, and as the residents, many of you have known how difficult it is to do the micturating cystoureterogram and so many things in childhood. So can we discuss a few of this?
Thank you, sir. Coming to this voiding cystoureterogram, there are absolute indications in which voiding cystoureterogram is recommended for children with antenatal hydronephrosis. And again, this procedure may be an urgent within 1 week or less urgent later within 1 month. The urgent indications include suspected cases of infravesical obstruction, including mainly the posterurethral valve. Presence of bilateral moderate to high-grade hydronephrosis is also a specific indication. Presence of ureteric dilatation, and later or less urgent causes like urethral causes stenosis or atresia or ureteroceles or cloacal problem. And another thing is if the child develops urinary tract infection during follow-up, to determine the degree of reflux if it's any present. Next slide, please. And the important thing here is precaution. It can be a painful and stressful procedure. Needs a very good parental counseling at the time of the procedure, and also with other specialist team where all the team members needs to be joined, and we need to give counseling. Now there are information leaflets on different aspects of this whole antenatal renal anomaly problem, including for tests also. And this is very important. Aseptic precautions are very much necessary, and urinary tract infection to be ruled out if any, or if it's any present, it needs to be cleared before the procedure, because there is evidence that iatrogenic ascending UTI up to 2% is there with this procedure. Prophylactic antibiotics is recommended along with VCUG in the first week of for mainly posterurethral valve. It's recommended. Next slide, please. Coming to the renal scintigraphy, the radionuclide studies, they're like your DMSS scan, DTPS scan, MAC3 can estimate differential renal function, which also detects renal scarring. And they determine the severity of obstruction by analysis of drainage of urine from the kidney, and decision can be taken for intervention like in case of pyeloplasty. And it can be used for diagnosis and follow-up of suspected pelvic junction obstruction. And it also helpful in detecting worsening renal function during every follow-up. If there's more than 5 to 10% decline in the renal function, it helps. Useful for diagnosis of other causes of urinary tract obstruction like uretrovesical junction obstruction in infants with moderate to severe hydronephrosis associated with dilated ureter, but there is no reflex on VCUG. Next slide. And useful for post-operative follow-up of pyeloplasty and uretrovesical implantation. Can also differentiate pelvic junction obstruction from multicystic dysplastic kidney. Also assess the effect of renal scarring and renal function later during follow-up. It has a low degree of radiation exposure compared to ventricular cystoureterogram. Better not to be performed before the age of 6 to 6 to 12 weeks to allow for renal function to mature. One more point I would like to highlight here is that especially during the follow-up of these problems in the second and third year, this vesicocystoerythrogram is very painful and stressful for older children. In those cases, these nucleoid studies are more helpful, like your MAC3 or DTPA, where it detects both the secretory and excretory function, less painful and less radiation for older children. Thank you very much.
Okay, we have kind of finished the questions. We are still on time at 9:53, and I'll just go to the end of the slides, and I would like to summarize what we have done today. Sorry. So basically, what we can say is that a lot of this, a lot of research has gone, a lot of studies have happened, and we see that a lot of renal anomalies are being picked up in the antenatal period with the wide availability of ultrasound and the wide availability of the 20-week ultrasound where renal anomalies are detected. Antenatal interventions, as we see, are not commonly done because the expertise is not available, or it's not possible to get that many number of patients and the cost of the interventions. In addition to that, there's also the fact that antenatal interventions may not have very good outcome. We are not sure of the outcomes. So it's more kind of a research research mode rather than doing a practice mode. But postnatal interventions of follow-up of patients is more or less kind of well established, and there has been continuous update of recommendations from various societies. So there's actually a society for fetal urology which looks at all this and the postnatal recommendations. So I have followed a few patients up of babies born with antenatal issues and then postnatal issues who got operated and are actually doing quite well and have joined engineering college. So even those people, there are these kinds of students who they may not grow well because the nephron numbers are low. They may have hypertension, they may have short stature. So all those issues might be there, but they still do well academically. So if anyone wants to share patient stories that have done well.
So I had a patient who was antenatally detected left hydronephrosis with a gross dilatation. He came to us at 5 months. We did an IVP. We couldn't get a DTPA. We didn't want to get it done. So IVP didn't show any kidney outline at all. It was almost non-functioning kidney. So we thought, okay, fine, we'll just go ahead and do a pyeloplasty or a nephrectomy based on the parenchymal thickness once we go in. But then we thought, okay, fine, we'll not do any heroic procedure in this child. We'll just do a PCM at 5 months. We just did a percutaneous nephrostomy. Then we reviewed it a month later with a DTPA scan. It showed around 44% function, which was very good for the baby. And then we did a pyeloplasty. Now the child is doing that. It's the most recent one.
Yeah. So the point what I wanted to make is detecting many of these conditions antenatally and managing them is actually a very fruitful experience, and many of the children do actually very well. They might get lost on follow-up, and that is where follow-up is important, because if they lose follow-up and they come later, then our kidney, which could have been salvaged, ends up with more damage. So it's very important to ensure that follow-up happens. So you have want to share anything? Yeah.
Just the thing, sir. This problem, what we experience in our clinical practice is, once the parents come to know, the mother comes to know baby is having some kidney problem, it causes real anxiety and they start worrying. And when we feel that we tried at that stage only, if we involve the whole team, pediatrician, neonatologist, urologist, nephrologist, and also fetal medicine people, at least over the phone or virtual, to rule out any syndromic problem which have bad prognosis. From that stage only, if we start counseling them, then they feel better. And again, options they give and options we give, they do well, and the outcome will be much better. That's one thing. And next thing is, now there are very well established evidence with this information leaflets are there. Just I was going through the Leeds Dinnery NICE guidelines. There are information leaflets not only for AN anomalies, for all aspects. For example, if the baby has to undergo Whiting cystoerythrogram, there is an information leaflet, and that we tried with our local language, and it brings a lot of anxiety in the parents and relatives, and that's helping us. Thank you.
Thank you. Thank you, Dr. Prasad. So I would like to thank the organizing committee of NeoCon, National Neurology Forum for inviting us for this conference and allowing us to discuss issues related to antenatal renal malformations. I'd like to thank all my panelists. Dr. Bish has left because he has a EB meeting right now, and Dr. Sunil Gothwal, who's online from Jaipur, and my panelists, Dr. Nijagal Math, Dr. Sarat Chandra, Dr. B.S. Prasad, and Dr. Ravi Sachan for working on this topic, because we have been discussing this topic for the last few weeks and preparing the presentations, etc. If there are any questions that anyone wants to ask, the easy questions you can ask me and the difficult you can ask to the panelists. I suppose there are no questions online or offline. So we'll call it a wrap. I am just hoping that this part improves in the next session, because that spent us a lot of time. Thank you very much. And maybe
I have a word to say.
Yeah.
Sir, I think just like pediatrics, IAP has come up with some guidelines for some diseases on the website. We have our own things for pediatric surgery. What are all the guidelines? What we need to do in most of the languages? Probably it is all there in Gujarati, Kannada, Tamil, Telugu. All we have done. You can see on the IAPS website. It will be good for telling parents.
Yeah. Can the panelists have a photograph before we leave on the? Can you switch off the background?
Thank you so much, sir, for moderating the session, and we're really sorry for the technical glitches.
Except from the technical glitches. कुछ नहीं कर सकते.
Hello, everyone. Moving on to our next session, which is Care of Extreme Preterm, moderated by Dr. Mahendra Jain. Dr. Mahendra Jain is an Associate Professor, Department of Neonatology, AIMS Bhopal, Joint State Academic Coordinator, Secretary, NNF Rajasthan 2017 to 2019, Organizing Secretary, Raj Neocon 2017, Organizing Secretary, West Zone Neocon, Organizing Secretary, KMCC Con, 4 publications and 2 chapters and textbooks. We welcome you, sir. And joining with us on stage are Dr. Rahul Kadam and Dr. Swapnil. So please kindly join us on stage. Just a reminder once again, please kindly follow COVID protocols, kindly keep your masks at all times, and please use our sanitizers as well. Thank you.
Okay, thanks to organizer to giving us opportunity. So we are here to discuss about extreme low birth weight baby multidisciplinary approach for intact survival. For this panel discussion, we have Dr. Shraddha Joshi. She will be online, and Dr. Sandeep Khandke also online. Here, Dr. Rahul Kadam is there, and Dr. Swapnil Vishkar is there. So Dr. Rahul is head of department unit, Department of Neonatology, Government Women's Hospital, Amaravati Hospitals, and he's a senior neonatologist. Also organized secretary of Mahapadicon and executive members of Maharashtra IAP. And with Rahul with us, he is a chief neonatologist, Bidari Ashwini Hospital, and he is area of interest point of care ultrasound. And various conference, he is the faculty, and he has a lot of publication in index journal and authorized in the neonatal chapters in many books. And we have Shraddha Joshi, and she is consultant pediatrician neonatologist and 14 years of experience in academic pediatric neonatology. So this is Dr. Swapnil Vishkar is also a DM neonatology he did, and he is the neonatologist and lactational consultant, New Era Hospital, Nagpur. So I welcome all the panelists in this panel discussion. So as we know, there's early preterm birth, that is the 23 weeks to 32 weeks, it has only 2% of total birth, but a huge mortality and morbidity. If we account all the neonatal mortality, it's about 50% neonatal mortality because of these babies, and about 50% also the neurological complication is there. In other word, if we say, if we can prevent these preterm delivery, or we can treat timely these preterm delivery, we can prevent almost 50% neonatal deaths. So that's why this panel discussion is very important. Now my first question to Dr. Shraddha Joshi, I hope he is online. Can premature birth be prevented? What are the interventions that can prevent premature labor? So it's to the Dr. Shraddha Joshi. Okay. It's not working. Okay, welcome, Dr. Shraddha. So
Thank
you
you,
already
sir.
had question.
Am I audible?
Your voice is not clear.
Is it now audible? Is it clear now? Am I audible?
No, wait for 2 minutes. Wait for 1 minute. So meanwhile, should we move second question? Dr. Sir, please unmute yourself. Dr. Shraddha.
Yes. Good morning. I'm not being able to hear you.
You are audible to me, Dr. Shraddha.
Yeah, but I cannot hear the moderator at all.
Okay.
So I don't know what is going on over there. I mean, I can't hear the moderator at all.
Well,
Okay, Dr. Shraddha, now I think we can listen you. So what to do to prevent these preterm newborn deaths?
Right. Like we know now, preterm deliveries, although there has been an improvement in the outcomes and a lot of preterm babies are surviving. But to prevent preterm deliveries, there are a few measures which can be taken. One is we should look at reversible causes. For example, if there is a history of smoking, then there is a history of acute infections or strenuous work that the mother is doing. Addressing all these issues can reduce the chances of preterm delivery. Suppose a mother comes in preterm labor, then of course we can, tocolysis is one option. There has been a lot of talk about progesterone, pessary, and cerclage, cervical cerclage. However, these have a role only in limited situations. For example, if there is a history of preterm delivery in the previous history, or ultrasound shows that the cervix is short, then there may be a role of cerclage or progesterone in the second trimester, but that is a limited role. So I think that is what we can do to prevent preterm deliveries. Earlier, bed rest, sedation, all these things have hydration in the mother, do not really benefit to prevent preterm deliveries. So I think that is what can be done for prevention of preterm deliveries. Although almost half of the patients, plus now there is with assisted reproductive techniques for deliveries, there are a lot of multiple gestations patients with IVF who are coming to us. So that is another reason why preterm deliveries have also, the incidence and number has gone up. And very often there is an indication for preterm delivery, for example, maternal or for the baby. So in those situations, wherever we can avoid preterm deliveries, like delivery less than 39, planned deliveries less than 39 weeks should be avoided unless really there is a indication maternal or fetal.
Okay, right. Thank you, Dr. Shraddha. So it's like now the few things that done and preterm delivery somehow prevented, but number of preterm deliveries increased because of ART. And we have limited things to do, but ultimately that the number of deliveries now preterm increasing rather than decreasing. So now my question to Dr. Swapnil is here. What intervention we can do to give these extreme preterm baby improve intact survival? Dr. Swapnil.
Yeah, thank you for the question, sir. See, most of the preterm births, they are not taking in place of a major cities. Mostly they are from rural cities or from district hospitals, this thing. So first and foremost thing is that improving the building blocks of the mother. If she is healthy, she is going to have a good baby. This is the first dictum which has to be there at a community practice. However, once you think that no mother can say that she is going to have a preterm baby. If there is high risk factor in the mother, then definitely there are some kind of interventions which can be done, which can improve the neonatal outcome. And everybody knows this, that since ages we are using antenatal corticosteroid, we are using magnesium sulfate. We are saying that in utero transfer should be there. We are saying that aspirin can be used to decrease incidence of a preeclampsia. And delivery to be happen at level 3 care. But this is all theoretical unless and until we keep in our mind and to produce this thing in our day-to-day practice. And the one and foremost thing which can be done if a pediatrician or neonatologist, they are involved in antenatal counseling of the mother. If they are counseled at least one session for every pregnancy, maybe it is maybe a group counseling, it helps in understanding the family, importance of these drugs, as well as to get delivered in the hospital if preterm deliveries is anticipated in tertiary care hospital. They have various advantages why they has to be delivered at tertiary care, at which an ICU facility is there. It reduces a lot of morbidities, maybe IVH, maybe neurological outcomes, they are better. So that has to be ingrained in parents' mind, and that has to go through obstetrician way. I think that should be the way in which.
Yeah, thank you, Dr. Swapnil. So it's true that if there's a preterm delivery is going, some important drug we have to give these other drugs, antenatal steroids, magnesium sulfate, aspirin, it's especially for preeclampsia. And we have to predict preterm labor. This is the very important. If you predict, then only you can give some tocolytic that we will discuss, and that the delivery should be in a center where all the NICU facilities are available. So here things as this is the important slide. I want to discuss this one. Actually, that all the drugs like antenatal steroids, magnesium sulfate, each and everything is about the more than 24 weeks. These are recommended. What to do that now the preterm delivery, its a definition is changed. Now is it 20 weeks to the 37 weeks. So what to do this gap 20 to 24 weeks? This is the very important. Things are, those are the recommended more than 24 weeks. Now what is the less than 24 weeks? So it's things like antenatal steroid, tocolytic, magnesium sulfate, antibiotic, and prophylaxis. All these things are considered in this week. When we go the 20 to 21 weeks, antenatal steroids, tocolytic, magnesium, it's not recommended. This is the important things. What is that comes out? Other things is the antibiotic prophylaxis. If there is infection, you can consider. So this is the things that is the current evidence for the less than 24 weeks of the things. So thanks to Dr. Swapnil about these magnesium sulfates. You have given a lot of informations. And there's different things that it ultimately decrease the CP. So if you can see less in magnesium sulfate less than 28 weeks, it work more well than the more than 28 weeks. It means 20 to 24 weeks. It's always if there's a time we should give magnesium sulfate to decrease number of CPs. Upper age it's a 33 weeks around. So already things are discussed that the in utero transport rather than the ex utero transport, it's very important to decrease morbidity, mortality. And if it is a very well equipped in utero ex utero transport, even the in utero transport decrease the chances of IVH. So this is the things. about this in utero transport. Now, if you summarize, these are the antenatal things. Interventricular hemorrhage you can prevent with the steroid, delayed cord clamping that we'll discuss later. And cerebral palsy, there is a magnesium sulfate already we have discussed. So this is a question to Dr. Sandeep Dhakade. He is online with us. Dr. Sandeep, please tell me, is there any role of tocolytic in preterm labor to improve neonatal outcome?
Good morning, all. Thank you, Dr. Jain. As we have discussed now, there are various modalities where we want to, by the time we want to give antenatal steroids, and tocolysis actually it aims to inhibit the uterine contractions and thereby prolong the pregnancy, at least long enough for a complete course of antenatal steroids. And that will reduce the consequences of the prematurity. And so we want to buy the time, and just to complete the course of antenatal steroids, we want to prolong the pregnancy. And so various tocolytic agents are being claimed to be effective, whether they are xanthine derivatives, whether they are beta-2 adrenergic antagonist. But nifedipine is preferred tocolytic because it is a cost-effective, it can be given orally, and it has shown the improved short-term neonatal outcome. Nifedipine is a very cheap, I will say instead of cheap, it is a cost-effective medicine, can be given orally, even a sublingual formulation are available. Even slow release formulations are available, and that's how there are various studies. There is one multi-center double-blind randomized controlled trial done in 22 to 33 week gestation babies, and that has shown a very positive effect. Yes, this is that study, and it has shown a very positive effect, and thereby improving the neonatal 24-month neurological improved outcome is shown there.
So Dr. Sandeep, so it's a time being you can prevent preterm labor, that is that through the tocolytic. So tocolytic definitely help it, but it will not prevent preterm labor, that the baby will be go in a preterm labor. So time being you can use. This is the study Tocoprom is going to do about the nifedipine. Results is going to, these are the, that the results are not there, but definitely this is the in view that the different study, it reduced perinatal mortality is there. Results are awaited. So this is the question, if preterm delivery is going on and all we know that the delayed cord clamping, it has a role. Now I asked Dr. Rahul, what is the exactly role of delayed cord clamping in preterm labor? And is umbilical cord milking, what is the evidence?
Can I have my slides, please? Yeah. So just concentrate on the first part of the slide, the first part. If there is a delayed or a physiological cord clamping at birth after ventilation, what I mean by ventilation is being established either by spontaneous breaths or by a positive pressure ventilation, what is going to happen that our lungs are going to expand and there will be increased pulmonary venous return to the left atrium. And at the same time, we have not clamped the cord. So there is an uninterrupted flow of the blood from umbilical vein to the left atrium. So our LV preload will be increased or it will be optimum if we delay or physiologically cord the clamp. So in that case, there will be a stable blood flow to the brain. And just look at the physiology here. If you clamp the cord early, when baby is still not breathing, what is going to happen that your lungs are fluid filled, your venous return is going to decrease. At the same time, you have clamped the cord, so there is a interrupted blood flow. So less blood is coming to the left atrium. So your LV preload is less and the less blood is going to go to brain. So there are a lot of So there's a lot of evidence that delayed cord clamping, the SVC flow will be better. You can see the timeline. If the cord clamping is delayed, the SVC flow is better, and that SVC flow is a surrogate marker for blood supply to the brain. So obviously, if there is a delayed cord clamping, baby is going to have a good blood supply to the brain, and it has a positive effects. I mean, there will be reduced incidence of IVH, and there are certain possible mechanisms how the IVH will be less. I already told. And this is a recent Cochrane which has compared delayed cord clamping versus early cord clamping. And with delayed cord clamping, there's a decreased mortality before discharge. There is a reduction in any grade IVH. And there's not much effect on the risk of BPD. Coming to the umbilical cord milking, we still don't have enough data. We still need to have a robust studies. So as of now, I would say big no to the umbilical cord milking. And this is as per recent NRP. So any baby, regardless of gestational age, if baby is not requiring positive pressure ventilation,
delay cord clamping at least for 30 to 60 seconds. And still there is a lot of studies going on where we can resuscitate baby near the mother when the cord is intact. And certain conditions when your placental circulation is not good, or if twin pregnancies, you can consider early cord clamping. So all babies, irrespective of gestational age, at least for 30 to 60 seconds, delayed cord clamping.
So yes, Dr. Rahul, and this is the almost 50% IBS you can decrease with this delayed cord clamping. And so because of this already, Dr. Rahul told it's very important. So now study is going on that how to do resuscitation with intact cord. Intact cord, what is the recent recommendation if baby is delayed cry, then immediately cord clamping. So now there is study is going on how to do neutral resuscitation with the intact cord. That's why this is the very important things of delayed cord clamping. So these are the possible mechanisms already discussed with you. And now my question to Dr. Swapnil, if baby is delivered other than delayed cord clamping, once baby cord is cut, then what special precautions we have to take at birth in these extreme preterm in newborns?
Yeah, so extreme preterm newborn, this pregnancy cannot be taken as a surprise. Should never be taken as a surprise that you are going to the for the delivery room and you don't know what is the gestation of the baby. Once you think that baby is going to be extreme preterm, you have to prepare yourself first and prepare your team that you are going to deliver a preterm, which is precious. Every baby is precious, but this is going to be a very extra precocious baby, precious baby. So first and foremost, delayed cord clamping is the norm. If you don't do delayed cord clamping, then you are not justifying the care for the baby. That should be the norm. Secondly, the most important thing in neonatology is temperature. Now, what is in temperature? For this kind of babies, they cannot maintain their own temperature. They have higher chances of hypothermia. Then there are studies that with a 1 degree drop in 1 degree Celsius drop in a baby's temperature, mortality or morbidity increases drastically. So measures which can you do is that you can maintain the delivery room temperature, which is say 26, 28 degrees. Next thing, you can use polythene wrap, cling wrap, which is used to avoid evaporative losses, heat losses. Then there are external thermal mattresses. These are all measures which are practical, which you can do at your district places also, at remote places also, because they are available. If you don't have cling wrap, which is available, which is commercially available, you can use the polythene wrap, which most of you are using as a gown in your NICUs. That can also be used to cover the baby. Now, once this baby's temperature is taken care of, then if a baby requires respiratory support, this baby should receive humidified oxygen, which is blended. And we have to monitor the oxygen level of this baby. We cannot say कि इसको 100% दे दी चलता है. Because the intervention which you do in delivery room is going to have a long-term impact in form of BPDSA, in form of IVSA, in form of various morbidities, NEC also. So if interventions done, the restricted use of oxygen, proper use of CPAP. If a baby is having respiratory distress at that moment in delivery room, use of early CPAP is beneficial. If a baby requires intubations, then early use of surfactant is recommended. So this kind of all parameters which should be there in your mind, just your team should be prepared. You can prepare a checklist that this baby is going to deliver. You can put it in your pocket or at a delivery room, and then you can just counsel parents beforehand, and you can go ahead with this.
Thank you, Dr. Swapnil. So this is the things like temperature, breathing, respiration, and delayed cord clamping are very important. These extremely low birth weight baby. Now my question to Dr. Shraddha, if baby is delivered, what is your preferred mode of respiratory support in these extremely preterm infants?
So I think since we are attending extremely small babies, preterms, 23, 24 weeks also now, the aim should always be non-invasive ventilatory support. Although there are a small number of babies who will require intubation and ventilation, but we do not want to intubate babies. So our aim will be non-invasive ventilation. As far as non-invasive ventilation is concerned, the most commonly used methods are three. One is nasal IMV, second is CPAP, and third is high flow nasal cannula. High flow nasal cannula, we know we do not use there is enough evidence that it is inferior when used as a primary respiratory support. So after the baby is born, the two modes that we have available most commonly used are CPAP and nasal IMV. Now between the two, there is evidence which is coming up now which shows that nasal IMV, especially for the very small preterm babies, for example, less than 25 weeks, less than 750 grams, nasal IMV will be the preferred mode of ventilation, both synchronized and asynchronized, non-synchronized, because we have seen that IMV reduces the need for intubation mechanical ventilation. And although there is no difference in the need for oxygen at the time at 36 weeks, however, need for mechanical ventilation and intubation can be avoided with using nasal IMV. Now, second is CPAP. CPAP is also another form of respiratory support, which is used as a primary respiratory support in babies. Now, these are the two most commonly used. There is studies which are going on high flow nasal HFOV, which can be used as a rescue method, but still I think more evidence is needed on it. And so primarily for very small babies, I would suggest nasal IMV, and for other babies, CPAP. And paying attention to the interface that you are using, which should be of the appropriate interface, for example, mask and cannula, which should be appropriate size for that baby. And nursing training, I think, is extremely important to avoid failure of.
So, thank you, Dr. Shraddha. So, that the established thing is the surfactant and CPAP, but now more and more evidence to the nasal IMV with surfactant now is coming. So, if after this we are going to talking about surfactant, now Dr. Sandeep, please, Dr. Sandeep is there. So, what is the indication of surfactant in extreme low birth weight infants? Is there any role of prophylactic surfactant in these extremely premature baby?
Yes, Dr. Jain, this is very important question. As we all know, surfactant is one of the mainstay of treatment is these extremely premature babies. And the surfactant is going to save these babies. So a lot of discussion is always going on what exactly is the indication for this surfactant therapy. So those extremely low birth weight babies who are ventilated with a mean airway pressure of at least 7 centimeters of water and who needs FiO2 of 0.3 or more in first 2 hours of birth, they definitely justifies the use of surfactants. And the first dose should be given as soon as possible after the birth, after intubation, preferably within 1 or 2 hours. Although with the increase in use of CPAP in the initial therapy, the timing of surfactant therapy may be delayed. Now the clear-cut indication is early use of CPAP with subsequent selective surfactant administration in extremely preterm infants. So with the availability of the CPAP, the role of prophylactic surfactant, that is giving surfactant immediately at the time of birth, is not indicated, is not suggested. Now, the efficacy of surfactant therapy is very important. Then early extubation is another thing that they are going up with the ensure technique, like intubate, give surfactant, and extubate. There are various unresolved issues. The role of aerosolized surfactant preparation, that is giving surfactant by nebulization. Recently there is one study which has been conducted on 454 babies, a randomized cohort study over across 22 NICUs, and that has shown very promising results of this giving surfactants by laryngeal mask airways. And even that is LISA, that is the less invasive surfactant application, is also another thing which has been quite in discussion. And that has also shown the promising results that instead of using our intubation or doing putting a endotracheal tube, just put the surfactant catheter. Vigon has come up with this surf cath, and you have to just, with the help of laryngoscope, just put this surf cath, instill the surfactant, and they take out that surfactant. So thereby for a lot of morbidity has been reduced, and these babies have shown good, wonderful results later on. Then another is the efficacy of the synthetic peptide surfactant preparations. That is also a little bit, under trial. Giving surfactant in the delivery room itself. Dr. Swapnil sir has very well said that 90% of our population is in tier 2 and tier 3 cities, where they don't have CPAP facilities in the NICU or in the delivery room. And sometimes you have to ship the baby quite a long distance for the tertiary care. And in such cases, even giving the surfactant in delivery room is tried, or probably that decision has to be taken by the attending neonatologist. All these guidelines are for for the guidance, but the ultimate decision has to be taken by the treating or attending neonatologist.
So it's a very good elaborative. Now things are going, what is the established is the ensure, but LISA it also going on. There is a evidence are there. This is the one of a long-term evidence. They are having very good neurodevelopmental outcome, but things are still is going on. So this is it's not a standard of treatment, but that the study is going on, and the future that we will got the LISA, it's a more effective and more patient friendly. So things is only established. This is the one of a Lisa taken in the delivery room, extremely low birth weight baby. This is also going on, and 2024 we will got the results of this study. Now my question
Just,
to
just
Dr.
1 minute, sir. It's Dr. Sandeep.
Yes, sir.
Generally, Vicon is a very good company, and they are providing with the catheter. But simple, we can use our RT also.
Exactly.
Use this Lisa, because there is evidence that chances of BPD is very much decreased when you use Lisa. I mean, you don't have to intubate the baby just for giving surfactant.
Correct.
So thank you, Dr. Swapnil and Dr. Sandeep. Now my question to Dr. Rahul Kadam: what is the optimal ventilatory strategy for prevention and management of BPD? Because since day one we have to make a strategy to prevent BPD. So please, Dr. Rahul Kadam.
So when it comes to the prevention and management of BPD, both non-ventilation should be the choice, as earlier discussed. So either CPAP or NIPPV, as we are speaking about prevention and management both together. Can you hear? Yeah. So non-invasive ventilation should be the way to go ahead. Yeah. And if at all your baby requires a ventilation, ventilate on a volume target mode, ventilate with physiological tidal volumes, low tidal volumes, 4 to 6, don't go till 8 and 10. Then use short inspiratory times, give adequate time for the baby to expire. Use optimal PEEP, positive and expiratory pressure, to recruit the alveoli. Use caffeine to facilitate the weaning. And early extubation, you should utilize the earliest opportunity to extubate these babies when you are on minimal settings. Surfactant is already discussed. Again, early rescue surfactant as compared to delayed rescue surfactant is going to prevent BPD for the babies who want it. And Lisa, I'll put a word of caution. Those who have a lot of experience of doing it, please do it. Inexperienced hands, please don't try. And you need to have your targets defined, target your saturations in the proper range. We don't want higher saturations. You target your PO2s, and those babies who have BPD, for them you can accept higher PCO2s, and a pH of more than 7.25 is fine for a respiratory function.
So thank you, Dr. Sandeep. So this is the very important. You start your ventilatory strategy since beginning of mechanical ventilator to prevent BPD, not the later on, and treat these BPD. And change नहीं हो रहा slide. Next slide दीजिए. Okay. So these are the things already discussed. We have to keep lowest possible tidal volume and appropriate PEEP. Now these are the things that already have been discussed, that the titrate your supplemental oxygen and should be more than 80% 5 minutes. Maintain 90 to 95%. CPAP already discussed, surfactant, early surfactant. Ensure it's a things, and on ventilator then it's a target ventilator targets in this there. Now later if the evolving BPD is there, then what to do, that the avoid endotracheal intubation. If baby is not maintained on the current mode, then you can use non-invasive ventilation. It's a good. And what is your target saturation once the BPD is the stable evolving? That you can go up to CO2 50 to 60, but more than 60, and maintain PO2 about 50 to 60. So this is the things, all are the evidence for the BPD. Now this is a question for Dr. Shraddha Joshi. Already we discussed that Dr. Rahul Kadam told how caffeine is important. So what are the advantage of caffeine other than apnea prematurity? Because we know caffeine for apnea prematurity. Dr. Shraddha, please.
Caffeine, we know, is one of the most commonly used drugs in the NICU, and it has a structural similarity to the adenosine receptors. Now, beyond use for apnea of prematurity, there are multiple uses. For example, it can be used, it reduces the chances of BPD, reduces the duration of mechanical ventilation. Caffeine is being used to help prevent extubation failure. So before extubation, we give caffeine to prevent extubation failure. Now, long-term data of the outcomes, the CAP, especially the CAP trial, is now available, which has shown that it improves the neurodevelopmental outcome of babies at 18 to 24 months. And now 11-year data is also available, which has shown that caffeine has reduced the chances of motor impairment in these babies. So caffeine has multiple benefits. Like I said, reduces apnea of prematurity, reduction in duration of mechanical ventilation, reduction in BPD, and improvement in long-term neurodevelopmental outcomes. So
Thank you, Dr. Siddha. So caffeine work in many ways. Now, I just especially this is a question that you already told. Now, Dr. Sandeep, please tell me, caffeine has how will it the prevent in BPD? What is the exactly preventive role, Dr. Sandeep?
Yes, Dr. Jain. Dr. Shraddha has already told that caffeine is of great use in the extremely premature babies. Now, this caffeine prophylaxis soon after admission has become the standard based on cohort studies. It has shown that earlier initiation of the caffeine, preferably in 2 hours to 3 days at standard doses, is associated with the lower incidence of bronchopulmonary dysplasia and lesser duration of mechanical ventilation among less than 28 weeks of preterm infants. We know the main risk factor for the bronchopulmonary dysplasia is a prolonged ventilation, and giving this caffeine can lessen the duration of this mechanical ventilation. So in view of more CPAP use, early administration of caffeine will definitely help in reducing the CPAP failure. So giving antenatal steroids, using caffeine, early surfactant, and avoiding the mechanical ventilation or reducing the duration of mechanical ventilation is definitely going to prevent the bronchopulmonary dysplasia. So recent studies has shown that when there is a if there is early caffeine therapy, it is definitely going to prevent the bronchopulmonary dysplasia in this extremely preterm babies. So, yes.
Thank you, Dr. Sandeep. And so what you do not wait for apnea, start caffeine earlier for the BPD effect. So start from at the time of the birth, earlier caffeine less than 3 days, it will be effective. So it also help in prophylactic caffeine in the extubation, and definitely that Dr. Sandeep told it reduce the duration of mechanical ventilation. So my next question to Dr. Swapnil, is caffeine therapy is expensive because start from the day one and continue for the 4 weeks, 6 weeks. So this is the belief that the people think it's expensive therapy. So please, Dr. Swapnil, please tell about this is what's about expensiveness or of caffeine.
Yeah. So I think this question, who are benefited from this question? Is it a poor people or there are somebody else? So these kind of studies, they are basically done to convince insurance companies that caffeine is required, and this is the statistics. And they talk in terms of dollars because mostly the studies are being done outside India. But when you come to ground realities of India and you think that caffeine is so much magical drug and it is going to cure and treat and then avoid BPD, this is not the scenario. At 2 years of outcome, once you give caffeine or not give caffeine, because I am not in a favor of continuing caffeine for a longer duration of time. Yes, it is an expensive drug. There are a lot of caffeine analogs which are very much cheaper, which can be used with little bit increase incidence of side effect. However, if you want to have an answer for this thing, yes, it is beneficial because you are going to prevent neurodevelopmental outcome. There is lesser incidence of apnea, lesser incidence of other morbidities. It is cheaper. But when you come to particular patient, then you have to think it after 32 weeks of gestation, of corrected gestation, does the baby actually needs caffeine therapy or just we are doing for the sake of being given in literature?
So
answer to
thank
this
you,
thing
Dr. Swapnil. He is very rightly said. We just have to improve, optimize other things before we are going to say that the caffeine prevent BPD, like our early surfactant, non-invasive ventilation, and how to do invasive ventilation. These are the equally important, even the more important for caffeine. But where the things are already established, they tell that the caffeine, it is the more cost effective rather than the non-caffeine, because the neurodevelopmental outcome somehow there is the better and short duration of the mechanical ventilator. Even the early discharge from the hospital where BPD is less with the caffeine. So for India, for the poor countries like us, that we have to improve our labor room. This is the very important early surfactant mechanical ventilation. Thank you, Dr. Sandeep. Sorry, Dr. Swapnil. Now this is the question for Dr. Rahul. How to make better use of postpartum steroid to reduce neurodevelopmental outcome due to steroids?
Can I have a slide, please? So there are a lot of controversies about postnatal steroids. Still, we are in a dilemma whether to give or not to give. So I'll just summarize the recent consensus in this slide. So Coming to dexamethasone, no routine use of dexamethasone in first 1 week of life, or even after first 1 week, if it is evolving BPD, no dexamethasone. Inhaled steroids, lot of studies are going on, promising results, but still we want to wait, and no inhaled steroids for prevention or treatment of BPD. Coming to the babies who are more than 1 week still on a ventilator, requiring more FiO2s, worsening RD, you can consider giving low dose dexamethasone, that too for a shorter course, not more than 7 days. Here again, hydrocortisone is not recommended. And for the babies who are extreme preterm and those who are exposed to the chorioamnionitis, in that babies, you can consider physiological replacement of hydrocortisone starting in first 48 hours in low dose. But with this strategy, there will be increased risk of late onset sepsis. And now we have a lot of apps or softwares available called as BPD calculator, where you can just put details of your baby and you can find out whether your baby is at risk of BPD, and then you can take a call whether to give or not.
Thank you, Dr. Rahul. So there is a no steroid, yes steroid. No, there is a middle way. When risk of BPD is very high, more than 65%, that is the things we have to use BPD calculator now available online. And we have to minimize steroid, but where it is effective, we should be use it. So these are the different things and already discussed. Now my question to Dr. Shraddha Joshi. Extreme premature baby should be viewed as a nutritional emergency because they are having lot of the things that the neurodevelopmental outcome is compromised because these are baby have malnutrition. Dr. Shraddha, please.
Like we know, with the increase in survival of these preterm babies with as high as 85 to 90%, our aim now is not just survival, it is intact survival. And nutrition plays a very important role, because if they do not receive aggressive nutrition and appropriate nutrition in the initial time, in the initial few days, we know that it has a direct impact on the neurodevelopmental outcome. Now, protein is the most important for these babies, and we have seen babies who do not receive adequate amount of nutrition and protein. They have a smaller head size and poor neurodevelopmental outcome. These babies are sick. Extrauterine growth retardation is another big issue in these babies which needs to be addressed. Our aim is to mimic or to make them grow like the growth of a baby of a fetus of the same gestational age would grow in utero, which is very, very difficult to achieve. So we need to address this as an emergency. And I think early TPN, starting feeds as early as possible, enteral feeding without the fear of NEC, and modification of feeds, post-discharge nutrition. These are the things which will help us to provide adequate nutrition to these babies, but it should be viewed as an emergency, and we should encourage early enteral feeding.
So yes, early aggressive nutrition was the part of treatment because there are a lot of EUs or babies are there, and the more and more protein was the recommended. But now I asked to the Swapnil, what are the principle of nutrition in the extreme low birth weight babies, especially? I want to ask about the proteins.
Yeah. So the thing that I'm very much interested in parental nutrition because I don't use parental nutrition. Most of the time I don't use it. Because the thing is that by 7th day to 10th day, I expect my babies to be on full enteral nutrition. So regarding minimal, the thing key to this answer is that minimal use of a parental nutrition. If you want to start with the parental nutrition, then there are various calculators of TP and how much carbohydrate. Ideally speaking, it should be like a 50% carbohydrate, 30% protein, and 20% of a proteins which the baby requires. Now, coming to how much protein this baby requires. Initially, we were struggling कि 2 gram देना है, 4 gram देना है, कि 4.5 gram देना है, starting कहाँ से करनी है, कितने, up to what level we can increase up to 4.5 grams or not. Then there are some harms also with this giving more amount of proteins. There are studies which are saying that mental developmental index, it decreases once you use higher amount of proteins. The concept of giving higher amount of protein is that non-caloric, the amount of calorie which is being provided by the TPN should not be used for metabolism or catabolism of the protein. That is called as a non-caloric protein ratio, which should be between like 150 to 200 depending upon the BUN. So don't use higher grams of protein, Start with a 1.5 to 2 gram per kg per day of protein and escalate sequentially to maximum up to 3 to 3.5 grams. Don't go beyond 4 gram per kg.
Thank you, Dr. Swapnil. So it's now true that not like more and more protein. We should be maintaining calorie protein ratio. This is the very important things that we have to maintain. More protein also the dangerous for the brain because it affect the brain growth. These are the different evidence showing that the not more protein around 3.3, but early protein is very important. If we see that the what is the things that the predict what is the neurodevelopmental outcome. So it is the first week protein intake, it's very important. Second week non-protein energy intake and the PDA ligation was there in this meta-analysis. So this is the things protein are important, but not very much proteins. Now question to Rahul Kadam, because we are using very, very less lipids. So I asked the basic thing, why, when and which lipids preferred in the extreme low birth weight infants?
Again, as Sandeep said, I mean, we do use partial parental nutrition. We don't use lipids, but if you have to use, why lipids? Obviously, they are energy dense source, rich in essential fatty acids and long chain PUFAs, which are necessary for brain and retina development. You can start as soon as after birth. On first day, start with 1 to 2 grams, gradually increase till 3 to 4 grams. Few studies tell like preterm, you don't cross 3 grams, but at the max, you should not cross 4 grams per kg per day. And which lipids? Obviously 20% intravenous emulsion because it is more physiological. And then we have a composite lipid formulas, what we call it as a SMOF, like soya oil, medium chain triglycerides, olive oil or fish oil. Why? Because they have balanced about all the lipids, particularly DHA, EPA, LCPUFA and vitamin E, and they will prevent baby from the oxidative stress. So if at all you're using, use composite lipid emulsions, not the plain lipid emulsions. Yep.
Thank you, Dr. Also, lipid, yes, there is a role of lipid along with the protein because it provides dense calorie and the 20% lipid and SMOF lipid now the preferred lipid as an intralipid. So this is about the all lipid. Now, Dr. Swapnil, what that all are saying that the early enteral nutrition. Now, this is a question to you. What is the advantage of early enteral nutrition?
So yeah, this should be the norm. जैसे हमने discuss किया कि direct cord clamping should be norm. This should be the norm in management of ELBW babies. The moment you think the baby is born, you have to think is baby को कब मैं जल्द से जल्द full enteral feed पे डालूं. Now there are studies in which people are starting directly on full feed if a baby's weight is more than 1 kilo. That is too much aggressive, I think. But we should be comfortable by giving more amount of feed to the baby rather than starting 0.5 ml 3 hourly, 0.5 ml 6 hourly. इसको थोड़ा देते हैं for gut priming. That should not be done. Now for gut priming, as minimal enteral nutrition is as says that it is around 10 to 15 ml per kilo per day that baby should receive. Which is not for nutrition purpose, but for priming the gut, for developing the immunity. But once the baby has tolerated this men, then there should be your speed of increasing the nutrition. Enteral nutrition should be up to 20 to 30 ml per kilo per day. It should not be less than 10 ml per kilo per day. Dr. Umesh Vaidya, he is very much into the nutrition. उनका एक जब वो बोलते हैं, once he said, एक बार सचिन तेंदुलकर को अगर suppose bouncer आ गया, does he always play defensive? No. Some of the times he go forward and play a big shots. So अगर आपको कोई बच्चा मिलता है जिसको feed intolerance हो गया, क्या entire unit should suffer because of that? The answer should be no. You should be aggressive with feeding. Then there are some kind of practices which withholds you by doing this thing, that is pre-feed aspirate, measuring the circumference, abdominal circumference, which is absolute nowadays. You can increase safely up to 20 to 30 ml per kilo per day. And also after saying that, I will say that use of what you call as a fortifiers for building up the calories should be started early to prevent EUGR. Because once baby is EUGR, he is going to have some kind of neurological abnormalities now or later.
Thank you, Dr. Swapnil. So we are worried about NEC after we are giving feeding. So now my next question to Dr. Shraddha, what are the preventive strategy of NEC? Dr. Shraddha.
We know that NEC has high mortality, morbidity. So everyone wants to prevent NEC. One, antenatal steroid use. Second is having standardized enteral feeding guidelines of the unit. For example, how much feed to start, when to start, what would be labeled at feed intolerance. And like we said, not being scared of starting enteral feeds and advancing enteral feeds if the baby is tolerating it. Then exclusive use of human milk, preferably mother's own milk. And if it is not available, then donor milk, which should be pasteurized. We should avoid use of acid blocking agents because we know they increase the risk of NEC. Most importantly, minimizing the use of empirical antibiotics. Now we know that babies who are on even 4 days of antibiotics until the culture reports come, they are at an increased risk of NEC. So trying to stop antibiotics as soon as possible. Probiotics, we know there is a lot of evidence that they help to reduce the NEC incidence, and with their low cost and limited adverse effects, minimal adverse effects, I think probiotics do help in reducing NEC. And now there is evidence coming up on the use of oral lactoferrin along with probiotics. However, that still needs larger studies, so it cannot be implemented as a standard policy. But yes, early starting enteral feeds, preferably human milk, and avoiding antibiotic use because you're altering the gut microbiome then.
So thank you, Dr. Shraddha. Yeah, there is a role of oral lactoferrin. It may become in the future. It is a good, maybe good of the good things. Now, my question to Dr. Sandeep, because what happened whenever we are going to say express human milk for NEC and neurodevelopment, it's very easy. But always what happened that the volume of milk is less. So how to optimize volume of milk? My question, Dr. Sandeep.
Yes, very correctly said, sir. We all know the importance of human milk and the mother's milk. And Dr. Shraddha ma'am and Dr. Swapnil sir has already said we need to start the milk as early as possible. And that's why we want to ensure that there is optimal milk volume is available. So that because immediately after the delivery of extremely low birth weight baby goes to the NICU, and we need to ensure how mother will continue her supply. So the first and most important thing is early breast emptying is important, and it should be initiated as early as 6 to 12 hours after the birth, either manual breast emptying or with the help of the pump. Secondly, frequent breast emptying is important, at least 8 times per day, and recommended is ideally 10 to 12 times per day. So every 1.5 to 2 hours, she can go for the emptying breast. Then there is double electric breast pump. It helps to the good milk yielding good milk volume. There is also a pumping bra where mother can keep her hands free and her breast are in position for the proper pumping of the breast. Then there is something like cluster pumping. Frequently, the breast can be emptied, and that also helps to yield the good volume. And then there is something like circadian rhythm. So there is early morning, there is a more yield of the breast milk. So they can go for the early morning breast pumping. Then when mother should be confident, she should be relaxed. She should have a good nutrition. She should have a good hydration. At least 104 ounces of water she should have intake in a day. And there are various other recommendations, like she can see the photograph of the baby while pumping the breast. So, and there is one more concept of extended breast pumping. Like usually we go on pumping one breast for 15 to 20 minutes. But if she continues to pump more duration, it will help to yield more milk volume unless it hurts. So if there is an ability to express around 500 ml of milk per day, it will be, we can call it a successful lactation. And I'm proud to say that we have 3 milk banks in Amravati, and one of them has been donated by us as a Rotarians for the city of Amravati.
Oh, great, Dr. Sandeep. So it's things that how to optimize milk volume. Thank you. Now, Dr. Rahul, there is a lot of controversy about prebiotics. So is prebiotic prevent NEC? This is the one of the thing. What strain, what dose is preferred?
Yeah, I think now it is beyond doubt that probiotics are helpful. And we have a lot of evidence. This is one of the opinion by Dr. Pathole sir, who has done a lot of research. And beyond doubt that probiotics are helpful in prevention of NEC, but you should be cautious about the selection of probiotics. So next slide, please. So whenever you use probiotic, it should be a combination of lactobacillus and at least one bifidobacterium. Coming to the dose, all babies less than 32 weeks, you can start with. Prefer a single dose, 3 billion units in a day. For extremely low birth weight babies, You start with 1.5 billion units till they reach 50 to 60 ml of enteral feeds. Dilute in milk. You should be aware about osmolarity. It should not exceed 600. And you can withhold it in any acute illness, any sepsis, even NEC or asphyxia, any acute illness you can withhold. And try and continue till 35 weeks.
So agree, Dr. Rahul. I agree probiotics are important. Now, this is the question to you, Rahul, because you are doing a lot of ultrasound. So is focused diagnostic NEC earlier than X-ray?
Yes. Yesterday also we discussed this. I think few delegates are there who were there. See what happens, ultrasound is more sensitive than X-ray in detecting any intramural gas, any portal venous gas, any free air, and any free fluid. Ultrasound Doppler is a better predictor of necrosis. What I mean by when there is a necrosis and if you do X-ray, only 40% of cases you will get a free air. Whereas if you do a Doppler, in 100% of cases, there will be absence of blood flow. So obviously, ultrasound is more sensitive. There are a lot of papers, one from Dr. Dinkar itself, and we have seen a lot of cases which we diagnose 1B or 2A on X-ray. If we do ultrasound, they are already progressed to 2B or 3A. So ultrasound definitely detects it earlier.
Thank you, Dr. Rahul. And we
Sorry
are
to
having
interrupt, sir. The time is up actually for this panel.
So now last 5 minutes, we try to things. Now, developmental supportive care, what is that, Dr. Swapnil, how to help in extremely low birth weight infants?
Yeah, this is very important while managing the preterm babies in NICUs. And yesterday we had a whole session for the developmental supportive care. It's very difficult to summarize in few minutes, but few slides which were yesterday, which were very much promising, that there are 7 petals, which is called as a care bundle while taking care of the preterm babies. You have to take care of his sleep, light, noise, touch, then skin care. This all comes under developmental supportive care. But ultimately, when studies they come at 2 years, they found there is no difference if you do developmental supportive care or if you don't do developmental supportive care. But by saying so, it doesn't mean that you are going to go away from developmental supportive care. It is very much essential for the baby to be in very friendly environment in NICU.
So yeah, this is the very important baby-friendly environment, and NICU is very important. Now, Dr. Shraddha, this is the second last question. What are the predictor of neurodevelopmental impairment in extremely low birth weight baby? How do we predict?
Like we said, smaller and smaller babies are now surviving. So birth weight less than 750 grams, extremely small babies less than 25 weeks. Those who have had severe brain injury, who have periventricular hemorrhage, especially more than like grade 3, or parenchymal bleeds, or post-hemorrhagic ventricular dilatation, those with a history of who have had meningitis or infections in the NICU. BPD itself is a predictor. Babies who have BPD will be at a risk of poor neurodevelopmental outcome. Then, of course, the family socioeconomic status, parental education, poverty, parental deprivation, all these things also contribute.
So yeah, these are things, but each and every low birth weight baby should have long-term follow-up. This is the very important thing. Now, this is the last question, Dr. Sandeep. How ROP screen is different in extremely low birth weight baby compared to the other preterms baby? Dr. Sandeep.
Yes, that is very important question, because we don't want only the survival of the babies, but we want the intact survival of the babies. And that's why it has a medical legal importance also. I want to tell one more important thing is aggressive posterior retinopathy of prematurity is something which is seen in these extremely low birth weight babies. And it is more common in these babies. And that's why it has been recommended that the ROP screening should be done as early as 14 to 28 weeks after 21 days after the birth. And the extensive laser treatment is required in these babies, that too by the expert ophthalmologist. And there is a severely constricted visual fields and high refractory errors seen in these babies. So there is a new advances in the treatment of these ROPs, and that is use of intravitreal anti-VEGF drugs like bevacizumab and ranibizumab, which has got the approval in the European Union also. And it has shown that it is rapidly emerging as the first line treatment in this aggressive posterior retinopathy of prematurity. I think this is an important thing, and we should take this take-home message.
Thank you, Dr. Sandeep. Actually, what happened in the posterior ROP, this is the zone 1 ROP. It's very difficult to handle by the laser. So these are drugs are available that we can use. Now I thank you to all my panelists and thanks to all the audience. So we are going to organize KMC Con in 2022 in AIMS Bhopal. So you are all are welcome. And thanks to all, and thanks to all the panelists online and offline. Thank you.
Thank you so much, sir, for keeping on time. So just can you wait for a second? We want to give a small token of appreciation from our side.
Thank you all. Thank you.
Thank you again. Thank you, Dr. Shraddha, and thank you, Dr. Sandeep as well. Thank you so much, sir, for your
Thank you.
participation. Just a reminder, kindly please follow COVID protocols. Please keep your masks on at all times, and kindly space out. We have a huge hall, so please space out, use sanitizers. Thank you.
Nursing workshop.
Good morning, everyone. I welcome all of you for the panel discussion on NEC preventive strategies and challenges in implementation. We have our moderator, Dr. Ashish Jain sir, who is Associate Professor Neonatology from Maulana Azad Medical College, New Delhi. He has many awards and publications in his field.
So good morning, everybody. Till the slides are coming up of my expert panelists. So we have a job of discussing, about necrotizing enterocolitis, neonatal necrotizing enterocolitis. You can skip this. Next. So to look at this, we have an expert panel. So we have Dr. Shilpa Kalane. She is a senior consultant at Dinanath Manganath Hospital. She is a qualified neonatologist with observership in neonatology from UK. Her special interests are perinatology, resuscitation in neonatal neurology, and has more than 30 peer-reviewed publications and 14 chapters written in books. And she has held a lot of executive positions in Maharashtra and NF. Welcome to the panel, Dr. Shilpa Kalane.
Thank you so much.
Is she logged in?
Yes.
Till she says hello to us, we have
Hello.
Dr. Shivnagowda.
Am I audible?
Yeah, very well, you are audible.
Yeah,
So
thank you
welcome to
so
the panel.
much for the kind introduction.
Yeah. So then we have, next slide, please. We have Dr. Shivnagowda. So he's from Kasturba Medical College, postgraduate. He done his fellowship from neonatology from Kerala. And he's associate professor at Department of Pediatrics, the Government Medical College, Gadak. And he has special interest. He is a nodal officer of the SNCU. And I just heard that he has, brought the level of the NICU from just oxygen to what it should be. Welcome, Dr. Shivnagowda. We have Dr. Murli Raj. So he's a consultant neonatologist of a level 3 NICU at Research Center, Kondlagalur, Thrissur, Kerala. He is a secretary IAP. He was secretary IAP, Kondangalur. Hope I'm pronouncing it.
Kodungalur.
Kodungalur. Okay. So 2015 to 2017. He's been a president from 2018 to 2021, treasurer from 21. And his special areas of interest are, preterm care, neonatal ventilation, neonatal hemodynamics, and point of care ultrasound. So welcome to the panel, Dr. Murli Raj. Then we have Dr. Shashidhar A. He's logged in, online. He's associate professor in neonatology at St. John's Medical College, Bangalore. So we have a Bangalorean who is online, and others are, there with us. So he's MD and DM neonatology, and he has special interest in research, medical education, simulation, QI, human factors, community neonatology. So a wide area of interest. He has 16 publications, and we are very happy to have him on our panel. Welcome, Dr. Shashidhar.
Thank you, sir. Thank you, sir.
Then we have Dr. Veera Raghavan. So he's a DM neonatology and DNB neonatology. Had a fellowship from Oxford, UK. He's an NICU trainee from Oslo, Norway. So he has had his training from world over. And he's a content expert for a lot of systemic reviews. So what you look and what you read and what you discern and, practice. So that's the great thing about him. He has a lot of publications, nearing 50 of them. He's an international and national faculty. And we are really pleased to have him as an expert in a panel. Welcome, Dr. Raghavan. So dear friends, necrotizing enterocolitis, as you know, remains a major cause of morbidity and mortality in preterm infants, more so in some of the units. Although the pathogens of NEC is under prevention strategy, so are being developed on a day-to-day basis, there are a lot of areas where there is confusion, controversies, and clarities to be sought. So even though there's a large ocean of literature lying around of NEC, so if you Google around PubMed, you'll find almost nearing 20,000 articles on NEC. Still the practice diversity is present. And that's why we have this panel discussion And we'll just seek the help of our experts on different domains as to how to take a decision on NEC. So let us start with the first question. Okay, I have this. So Dr. Murali Raj, what are the important preventive strategies for NEC? What strategies are there? Are they really proven to be beneficial as with regard to the outcome of the NEC or reduction of incidents? And what is the quantum of benefit? Which one benefits more? Which one benefits less? So can you put some light on this?
Yes, sir. Thank you, sir, for the question. As we all know that NEC is a disease that we all fear to see, because whenever an extreme premature baby or a very low birth weight baby is in the NICU and we stabilize the babies and on full feeds, we are happy, bystanders are happy, then this fellow comes. So there are a lot of things that we can do to prevent this NEC in our NICUs. So one of the major thing is, the best, the most important risk factor for any NEC is prematurity. So we can do what we can do to prevent prematurities. So in the previous panel discussion, we had some light on how we can prolong the preterm labor if we can. So many times it is not possible. So what we can do, first thing is that, we all know that antenatal corticosteroid has a proven benefit. Yes, it reduces necrotizing enterocolitis by about 50%. Then the baby is born. Do we do delayed cord clamping? Yes. Then now the norm is to do the delayed cord clamping at least up to 60 seconds. Then prevention of anemia, and also one important thing is restricted transfusions. So reduce the number of pricks in the NICU, because in latest studies it is shown that about 40 ml per kg of blood is lost in previous venipuncture procedures in the NICU in very low birth weight and extreme low birth weight baby. That's a huge number, and we will be flooding the babies with repeated transfusions, increasing the risk factors. Another one is we all know that giving mothers on milk. There is no much thing to be talk about that. Yes, it reduces NEC by about 2/3%. And if it is not available, we do PDHM, that is donor human milk. It also reduces the incidence of NEC by stage 2 and more stages NEC, 1.7 versus the 6.6%. Is about 5% reduction in the rate of necrotizing enterocolitis is there. And in the previous panel discussion also, we had heard about advancement of early undernutrition, aggressive undernutrition, slow and fast advancement of feeds. So what is in the various studies, what they have done is that the slow advancement of feeds means it is about 15 to 20 ml per kg per day advancement like that. And the faster will be 30 to 40 ml per kg per day. So what they have found is that in various studies, there is no much difference in the NEC. But what is important thing is that in slow advancement of feeds, the sepsis rate was high. So it's very good to start early feeds, aggressive enteral nutrition with the mother's own milk. Then the next thing is probiotics. We also had a discussion on probiotics in the previous panel discussion. Probiotics in very low birth weight babies, yes, it has got a protective effect in preventing NEC, and number needed to benefit is 33. But the thing is that actually the level of protection comes down when we give this probiotics to this extreme low birth weight baby, because many studies are there, but those studies are not adequately powered to give a strong recommendation for probiotics in very extreme premature babies, especially less than 26 weeks of gestation. Then comes lactoferrin. Lactoferrin, there are studies like ELPHIN studies or LIFT trial. There is, it's actually a word of controversy. Actually, these trials actually don't recommend the use of routine lactoferrin for the reduction of NEC, because the relative risk seem to be one only. So there are certain other things are also like stem cell transplantation, anti-platelet activating factor infusion, like there are some of the research methods.
Very well said, sir. So you can see that the gist is that whenever we talk about NEC, the prevention goes with management. So the prevention is the main, crux of preventing NEC. There are certain managements where we need not do certain things like go slow on feeding or take alternate milk feeds, but definitely we can avoid certain things so that, the NEC doesn't occur. With regard to, the prevention and the management, there are certain, areas which have shown benefits in some studies, have not shown benefits in some studies. We'll discuss later as to what to, catch up from those literature. Dr. Shivanagowda, we just heard about the benefits of the preventive strategies, and Dr. Murli, aptly said about the quantum also, that how much reduction is there. What is the way one can use these strategies? Is it a single best strategy one chooses always, one by one, bundle branch? What is a model we actually introduce in a nursery?
So we have NEC care bundles. So when you see like human, these are the care bundles, human milk feeding. So the mothers, most of the times it will be difficult to get the same mother's milk. We have to counsel the parents to get the breast milk as early as possible. So they should start pumping early within 6 hours so that we'll get the human milk, which is more protective. So, and if the same mother milk is not available, donor human milk, which is the next best thing. There have been studies compared